Hello, I'm Fraser Ratchford with Canada Health InfoWay. I'm pleased to present to you a webinar on clinical synoptic reporting, which was conducted as part of our ImagineNation Outcomes Challenge. The Outcomes Challenge seeks to accelerate the growth and spread of key technologies in 4 categories. To learn more about the challenge, please visit the challenge website. In the clinical synoptic reporting category, University Health Network was the first place recipient of our Trailblazer Award. During this webinar, they will share their experience implementing and adopting their solution, and will lead a discussion with others. To start things off, we will play a short video created by UHN for the challenge, and then their presentation will follow.
So at UHN, ENotes has served as a platform for us to capture information for discharge summaries and procedure notes. This allows us to more effectively communicate with our referring physicians, including primary care physicians, other specialist referring clinicians, consulting physicians in the inpatient and ambulatory setting. And it also allows us for patients that are either readmitted or seen in emergency departments to receive timely documentation. So we use ENotes presently either as a print document that we hand to patients at the time of discharge, while we simultaneously auto-fax to the referring physician. In the future, we're very excited about making them available through our Connecting GTA Regional HILE initiative.
Okay, so now that I have pretty much all the information, I just want to summarize things for you and show you basically what the plan is going to be over the next few weeks, okay? So I'm going to show you some pictures here of your colonoscopy, actually. We have these because all of the images are stored on the hospital computer systems. This is what normal colon looks like, and you can see on this picture here, this is what the tumor looks like that they found. Okay. This is where they took the biopsies that came back showing cancer. I'm going to switch now just to a diagram of the colon to give you a picture of what we're going to need to remove. This is what your entire large intestine looks like, and the tumor is here, and we're going to need to remove this piece from here to here. After we've done that, we need to rejoin the ends.
ENotes has been successful for 2 major reasons. One is the user-centric design, and the other is integration within the hospital information systems. Through user-centered design, we've ensured that we have appropriate content. We've actually used our human factors team to help us with usability and workflow management. This has led to significant adoption and minimal training requirements. As a matter of fact, being an academic organization with many trainees, we find that many of the clinicians actually learn in real time by using the ENotes documentation tools as a form of best practice knowledge transfer. The integration within the hospital information system has allowed us to use functionalities such as medication reconciliation, and it allows us to pull data from the clinical data repository, including lab, medication, and diagnostic imaging information. Through synoptic reporting and the use of standards such as SNOMED CT, we're better able to use information to advise clinical care, perform better research, and have the data that's required for us to make better decisions at an organizational level around performance management and leveraging existing resources. In the future, we look forward to making this information available through patient portals and personal health records to allow patients better tools for managing chronic disease and continuity of care.
So there you go. So without further ado, I'm going to introduce Tim Tripp from UHN, and I'll let him introduce the rest of his team here with him today.
All right, thank you, Fraser. So I'm Tim Tripp. I manage the medical informatics and systems engineering groups within the IT department at University Health Network, and I'm joined by the now famous Dr. Ross House, who you saw in the video, our Chief Medical Information Officer, as well as Kelly Lane and Mary Lamb, both of who have been instrumental in keeping our documentation efforts moving forward over the years. So I guess we'll start with a bit of history. We've actually been at this in one form or another for over a decade. Our initial efforts around online documentation began with our discharge summary project, which was actually kicked off by one of the physicians who worked with us, who had actually developed something on his personal or on his work PC sitting in his office that he had shared with his friends in general internal medicine, and then we took that and made it more enterprise-wide. So, but the real focus on this initially was just really around communication with the community physicians, because things were not done very well at that point. We did also look around at various points. We've done this a number of times, looked at the market to see whether there was something that we could purchase to help us do this rather than build it. But we were never, when we did that, we were never able to find anything that really met our needs, so we continued to build in-house. And that's allowed us to actually integrate things quite nicely, because we were basically building things that we knew would integrate with clinical workflow within our hospital and the clinical systems. Just sort of talking about what we were trying to fix at the time. This was our standard of communication, and you probably still see things like this today. But this was our handwritten Dear Doctor letter, which is what we were trying to improve. But then after that, in looking at that, rather than just recreating that letter, we did do a fair bit of research to identify, what are the known deficiencies around communication with the community physicians, and then worked closely with multidisciplinary teams at various points to develop a product that would actually improve the processes and the practice. So what you saw, this was sort of that was when we started down this road, which is now expanded to, OR procedure notes, clinic encounters, some of the stuff that you saw in the video, but it really began with the discharge summary. But it helped us to develop a web-based platform for delivering this type of information that actually pulls in, Kelly's rule when working on all of these was nobody is ever going to have to enter anything that is already captured electronically somewhere within the hospital. So we've managed to do fairly well at that. And this is now what our outputs look like. They're actually legible. There's a lot going on underneath here. We even, with the integration with our medication reconciliation application, we're also able through the discharge process to come up with a discharge prescription as well. Architecturally, this is essentially how all of our applications work. Like the application is separate but integrated with our electronic patient record. So it launches from the electronic patient record and passes across demographics and allergy information. The notes applications can then also pull information that exists already within our clinical data repository, such as the medications labs and radiology information. Once a note is completed and signed off, it then gets sent back into the electronic patient record through an HL7 feed, and where it then piggybacks on to sort of the standard dictation and transcription processes and gets auto-faxed out to the community physicians. We're hoping at some point to be able to leverage, secure email to get rid of the auto-faxing component. But essentially, that architecture is how all of our applications work. So with the discharge summary, some of the outcomes were actually fairly impressive. I mean, most of our patients actually have a completed discharge summary on the day of discharge. So it really cut down that time, and that's been the big thing about increasing or improving the communication with the physicians, with the community physicians. It also means, health records people love this because it means you're not paying to have notes transcribed that have been dictated. Because we've been able to integrate all this other information sources without people having to retype or dictate things, it actually improves the data quality within the notes. So So yeah, like I said, well, GIM, which is our largest service, fully a third of all patients within UHN come through general internal medicine. They use the discharge summary application 100% for all of their patients. There are other services that use it heavily. It's not mandated yet, but we can talk about that a bit. We'll talk about that a bit later. But it's really helps to improve that communication and cut down time. Now to talk about the procedure notes, part of the goals here were the same, to actually improve the chart completion and communication with external community physicians and other care providers. But as Peter mentioned in the video, one of the interesting byproducts that we saw with these tools was, because we're a teaching hospital with lots of trainees, the notes are built in such a way that actually helps them learn proper procedures when doing a surgical procedure. We've actually had residents comment that when they've been taking their exams, all they had to do was visualize what they filled out whenever they were doing an endoscopy procedure note or whatever. So that's really cool to hear, and it wasn't something that I think we knew would happen when we started down this road. And then, we're all about synoptic reporting, so this is, these are giving us all of the discrete elements that we can use for ministry reporting, research initiatives, and the like. So again, you've sort of seen this sort of template within the video, but all of our notes look very similar. We had the great fortune of being sort of co-located with our healthcare human factors team for a number of years. So I think a lot of their teachings rubbed off on us when we were developing these applications, and they've actually gone through and provided feedback to us as well around things that we could improve. But the look and feel of all of our notes are very similar. There's that tabbed approach with some common elements. Some of the tabs are unique to a particular note. Everything that you see on the note is actually encoded in the background. All of these data elements to SNOMED CT, and that is captured in the background to a SNOMED concept. One of the cool things we've been able to do recently is actually sort of drive the note content based on SNOMED. So it's actually taking advantage of that semantic relationships of terms within SNOMED to actually drive the content on the form, which is really neat. We're really starting to just scratch the surface of the power of SNOMED CT. So let's see. So again, and we would often, whenever we were going down the road of doing a new note, the first thing we would do is actually go and we would never go to clinicians and say, what do they want? We would go and look at what they've been doing. So we would actually review the notes that they've done in the past and see if we could come up with a starting point template that met their current needs and have that as a discussion point. And that's always made it a lot easier to move forward with these. So, and again, we've been doing this for a number of years now. We started in the fall, went live in the fall of 2006 with our first 2 OR notes. Now we've got more than 20. It's actually lost count, but it's over 20. And again, like the discharge summary, everything's fully integrated with our EPR. We've also started looking at partnering with external organizations and looking at different models of delivering this. Our newer notes are also built so that they could be more easily launched elsewhere. So some of our lessons learned. Collaboration with the clinical users of the systems and the data they generate. That's been crucial. Like all of our projects have been multidisciplinary in nature. Depending on what we're building, it would involve obviously the physicians, potentially nurses, pharmacists, health records people, performance measurement people, the coding and abstracting folks. Peter had mentioned the user-centric design, that we're, again, very fortunate to have a healthcare human factors group at UHN, but doing that usability testing it has been critical for us. Having clinical champions, like Dr. Rothos, and, certainly for our work around endoscopy, and then finding others is a critical success factor with these. And again, I've talked about the integration where possible, so that we can access or leverage data that already exists, rather than having to re-enter things. Having a robust infrastructure, that's really been a huge lesson for us. We've probably lost a couple of years of traction in moving forward, just dealing with performance issues around our Citrix environment through which our EPR and therefore our notes are delivered. So you need to make sure that you can actually support and maintain these applications if you're going to go down this road, and that of course requires an organizational commitment. So all of those are important. So back on the infrastructure. So we're currently upgrading our Citrix environment. Well, actually, we've done an interim step, which has made a huge difference. I had the joy recently of having one of the nurse practitioners in our cardiovascular service call me for the first time in 2 years to talk about next steps for the discharge summary instead of complaining about how slow everything ran. So it's nice to finally have that behind us, and things should just get better. Now that that's out of the way, we're actually looking at trying to achieve 100% compliance with the electronic discharge summary, and that will mean having to customize some new discharge summaries for surgical areas. We're working with general surgery. We've been through a CPAC initiative, which was funny which was interesting because at the same time we were doing that, another surgical group came to us directly with with wanting to do the same thing. So again, there's definitely demand out there. And as we do that, we're also expanding our OR notes to other specialties and working with national organizations such as CPAC and Infoway around developing national standards for data collection and reporting. So yeah, lots of exciting stuff in the future. I think. Just one summary slide. We've definitely met a clinical need. We've improved communication with the community and even within the hospital as well. And again, that standardizing of templates for reporting and research has been really crucial. So I think that was the last slide, and you've seen the video. So.
All right. Well, thank you for that presentation. That's very informative. We're now opening up the questions to the floor. I always take the prerogative to ask the first question. And so, Peter, I'm going to direct this at you because so it seems you've come a long way, but that crucial step was how do we get the clinicians involved, and what sold the clinicians to, first of all, agree that this was a good thing, and then how did you get them to start using the solution?
Nice question, Fraser. And first of all, I'd like to thank Infoway for not only sponsoring the challenge, but recognizing the work here, and I think most importantly how we can work across the country nationally to continue this sort of work and just advance it and make it better. So specifically around the clinical change management, I think the drivers now at a clinical level are even stronger than they were then, and they're all around delivering quality care and being able to demonstrate appropriate outcomes in clinical management. So I think in the early days, and you can see where Tim sort of indicated about a decade ago, I think a lot of this type of philosophy around delivering clinical care was primarily in the larger academic centers, the larger community hospitals. But I think now, as a result of the focus on quality throughout the system, it's very much ingrained
in, clinicians, whether they're working in a smaller community-based hospital or whether they're in a large urban center. I think a number of us have recently had the privilege of learning about what's going on in the Yukon and, various sort of parts of the country that initially we thought were fairly remote. And we see there's a real focus on delivering the best care that we can and measuring outcomes and doing that. Now, the reason I'm sort of emphasizing that is the only way to be able to fulfill that mandate is to be able to capture in real time at the point of care the sort of data that we need. And with existing, traditional methods around transcription or handwriting, we don't capture the sort of discrete data elements that we need. And then we lose, the opportunity for, some of the processes that Tim very nicely outlined, everything from reusing information that's captured. And, the philosophy is, the trained clinician should capture that data accurately the first time around and then should share it with the other members of the care team. And, that's a philosophy that Kelly and the team used when they were looking at, the various sort of business requirements. The other sort of elements obviously include the knowledge translation, the change management that goes into that. A specific example that I could bring in would be, around, let's say, some of the procedures like endoscopy notes. It hasn't been standard practice to include an underlying patient risk status. And there's a standard scale. There's an ASA, anesthetic risk scale that's very easy to follow, and it's simply one click to be able to identify, that risk score with a patient. The reason that's very important is when you analyze outcomes, it allows the individual clinician or the organization or the province to look at how many procedures they're delivering to patients with various risk status. That's impossible in the transcription world or the handwritten world. So, many examples. I'd say around the discharge summary, one of the reasons that we landed on that, this will be my final sort of comment, is there's a blend of, I think, positive and negative reinforcement. So one on the positive side was to be able to discharge patients that are often complex into the community with an appropriate, summary of their hospital admission and their medications. Since then, we've been able to layer medication reconciliation on, that sort of framework. But I think more important than that is the fact that patients now are expecting some sort of timely communication. And so that when they are seen in follow-up in their primary care physician, in the CCAC or wherever they're going, they expect that information to be there for their visit, which may be within a couple of days for wound management or within a week or two to see their primary care provider. So there's also that expectation, but there are also financial rewards. And I don't know that much about the fee schedule in other provinces, but in Ontario, the ministry a few years ago brought in codes for the most responsible physician, where completion of a timely discharge summary within 48 hours generates a reimbursement. I don't know if it was engineered this way, of $48. So that again is an incentive. Now again, from a senior management perspective, part of our balanced scorecard is timely discharge summary completion. So you can see when you align all the drivers, from quality care, financial reimbursement, senior leadership, you can see how you can easily drive, a common thread through the entire organization. I think that's sort of what Tim and the team have been able to do very successfully over time. My great regret is that it's taken well over a decade to do what, in many cases, is a fairly simple change in process.
So that sort of leads to a nice question for the team then. So if you look back, so if it's been that decade to sort of drive change, what would you do differently now that you know what you've done already? Is there anything that you think, okay, I think, Tim, you showed a statistic of, is it 92% are now being done in 14 days? Was that the right statistic? So now that what you know, what would you do differently, or what have you kind of learned that you think others would benefit from? Tim's thinking, I'll remind everyone else to feel free to ask questions. You can either ask them verbally, you can show your hand on the WebEx, and then we'll call out to you to ask the question, or you can also submit questions using the chat feature of the WebEx as well. So any one of those forms, we're happy to get your question and have the UHN team answer it.
So, the one thing that I probably complained about the most throughout the presentation was some of the issues with our infrastructure. Going back, I think there was a point at which we had decided whether to launch web applications sort of outside of the Citrix environment or keep them within. At the time, it made sense to do that, but what that also meant is that actually to this day, we still have to develop for Internet Explorer 6. So we've made some technological decisions along the way that I think, again, in hindsight, were probably not the right ones, because we've had to depend on that Citrix environment, which has been problematic for us. At the time, it also saved us because, back when, IE6 was still fairly new, it meant we only had to develop for one browser. But that's not realistic anymore. So, all of our stuff is now cross-browser compatible. So yeah. But I also think we're quite excited about this because this is also going to give us a chance this award is going to give us a chance to really blow our own horn within our organization because we tend not to do that.
Yeah.
That's
what I was thinking.
Yeah. So this is going to give us some great visibility within the organization because I'm sure even within the IT department there are good chunks of people who really don't know what we do or why it's important. So.
Can I ask a question?
Sure.
So for those on the line, my name is Cassie Fraser. I work here at InfoWay. But in listening to your presentation, I'm completely impressed, first of all, with the content and what you've been able to do, but as I've been listening to your change management approach as well, right from how you've talked about, in your build scenario that you had your organizational objectives aligned with your business requirements, the clinician input, like everything you've done right. And I work with a group across the country that talks about these constant challenges, and kudos to you and your team for getting all those elements lined up. One of the things that I was wondering about as you were speaking, I guess I have two questions really, about your infrastructure point. So as you've come up with the challenges with that, did you find that you had to advocate with the leadership to try and get them to listen to you and hear that this was a burning pain, or was it an easy sell and you could get that support? Wondering about that challenge.
I'm wondering, but I'm censoring myself. I think it took us, the better part of 2 years to convince the powers that be that the problem was not our application.
Yeah.
So that there was something wrong in the infrastructure, and eventually it just got so bad that we actually had a lot of added weight to our case from elsewhere in the organization. I love doctors who are absolute geeks and can call you up and say, there's something wrong with your Citrix environment. I can see that it's dropping packets. And I'm just thinking, I don't even know how to do that. But, when you get people like that engaged, it's great. So
it strikes me a good analogy for you would be like a homes-on-homes kind of scenario, right, where some builder has gone in and done some massive, 2,000 square foot renovation and forgot to build a foundation, right? You could probably have some fun with that in a town hall or something. The other question I was wondering about, you talked about SNOMED CT, and I think from our perspective, we're excited to see that you're using standardized information. I'm wondering if you had any challenges with the clinicians in trying to get them to agree on terminology or whatever to map to it or agree what it is at the back end.
So maybe I can sort of comment.
Sure.
Cassie, I'd say one of the, I think there were two major sort of challenges in terms of, the time that you see in bringing this over the past decade. So one is the realization that this is really sort of middleware, and like a lot of organizations, we're dealing with a best-of-breed sort of system. a lot of legacy sort of software, hardware sort of platforms. And the problem with this sort of approach is, the reason it's middleware is it's very hard for industry to actually generate a good cost model to get in there and do this kind of work. Mm-hmm. Then on the other hand, when you're in an organization, it's very difficult to get the resources to deploy the kind of creative people that you're seeing here, and we have even more people on the team to be able to get their time and focus. And a lot of this is built on open source, open standards, sort of work. So it's not such a problem in terms of the technology costs, but it's very expensive in terms of getting the right personnel and the focus on this. So a lot of the initial seed work was done under the radar. Okay. And so I think part of our approach would be to try to anticipate the needs of the organization. So when we heard that, Program X would have to report on, let's say, certain quality indicators, we knew that Program X wouldn't be able to deliver on quality indicators on their existing sort of process. So we would kind of create a solution for Program X, mock it up, take it to them, get some champions, and then actually put it into production. And that way, Program X would, go out and sort of, to Tim's point, have a lot of early adopters, a lot of folks coming on. Then you start winning over those people that are the folks that never thought it could be done. And the next thing you know, you have a lot of demand from other programs, and you generate this sort of organic demand.
Right.
I think part of the problem with that is when you reach a certain level, you get into sustainability and version control and everything else, and the fact that our organization is doing this work, and then the place across the street or across the country is doing the same work. And so where we see, a lot of opportunity, and we're doing this, I think, a lot more effectively, is using national and provincial organizations like InfoWay to help us collaborate better, right? And that's, if you don't mind me saying, where the standards are important. Mm-hmm. Because as we look at these little homegrown web-based solutions, we're keeping an eye on the highs and moving to the cloud. Mm-hmm. And that'll get us out of this kind of Citrix bottleneck where, once they're sort of launched within that sort of HIO model, we'll be able to generate all kinds of, applications that'll meet the needs of the clinical environment at the point of service that'll tie in, to that sort of ecosystem. So I think it's great to see where we've done a lot of back-end work within our organizations. Tim, mentioned the infrastructure. I think InfoWay has done a lot of work on a more national blueprint for infrastructure. Where we've succeeded, I think, with SNOMED, and I think, the great success here is most of the clinicians using this don't even know what SNOMED is. Yeah. And I would say the real model around this is have the user, utilize terminologies that are familiar to them, and then match them behind the scenes with various, coding and standardized reporting. Right. We used that very, very early on with, even back in the late 90s when we started on some of our clinical systems. And one of the challenges we gave our developers, and this is, one of the things that I sort of used at that time, it was true. I said, folks, you have to design this for people that think Windows are what you open to let in the breeze. Because at that time, most clinicians didn't know what an operating system was. Most of the PCs were being deployed by administrative personnel, not clinical personnel. And the idea was you have to focus on very much the interface, right? I don't know if that answers the question. So when you see the SNOMED, we're talking about it. Yeah. The clinicians are not talking about it. Yeah.
No, I think that's perfect. But definitely when you think about rolling that out to the bigger level, and how do you make sure that the terms you've mapped it to from UHN maps to, the guy across the street or whatever too, that's where the challenge will probably come in at the end.
And that's where we think dividing and conquering. Yeah. That's where, drilling in. And that's I think, and I'd like perhaps Kelly and Mary's left, but Kelly can comment further, that is a huge amount of work, and it requires clinicians that are knowledgeable in terms of best practices that are evolving, terminologies that, just like the English language and other languages change a bit over time. They have to take ownership. And, that's where we as a national community should be able to divide and conquer. And CPAC has done some great work in pathology, surgical synoptic reporting, and other areas that we'd like to, be part of and replicate in different areas.
That's perfect. Well, congratulations to you and your team. Well done.
Kelly may add, she's kind of our...
the one thing that we've done internally is we have a centralized Nomad BT terminology server that we use for all of our applications. So really you only have to manage the terminology in one location, and once you've done the mapping, you've done it already, and we recycle a lot of what we use. So that, I think, is a model that's worked well for us, that other organizations might want to look at. It doesn't have to just be Nomad BT, it could be other terminologies, whether it's Boink or other pieces that you're using. But it's allowed us to have a centralized place to house and tap into. So it's not application specific, and we use it across a multitude of applications.
Did you make that decision early on?
We did. So one of our engineers. And the unique thing about our team is not only do we develop, we also support everything.
Right.
So because of that, we try and minimize the amount of paying down the road. So we're very conscious of our design up front because we're stuck with all the problems. We don't just hand it off and another team supports it. We get all the calls after the fact. So we wanted to make sure that it was seamless and that it is very, very low overhead from a supporting perspective. So that's why we've made that decision.
That's helpful to think about your operational structure after that tied right in there.
Absolutely.
Yeah. That's good. Thank you.
So people on the call, are there questions for the team at UHN?
Fraser, it's Bhavna here. I don't, Kathy actually asked my question. I just wanted to congratulate the team on their successes. And the one thing I learned from this presentation is the importance of engaging other stakeholders in the organization other than the clinicians, such as the folks in the health records department and the individuals who are focused on performance management. So congratulations. It's a great piece of work.
Thank you. Thank you.
Anyone else have a comment or a question? A question that I'm sort of taking up on my other team about clinicians. So how do the community physicians react to this standardized? So did you get input from them as well? And, what's been their reaction to this?
Fraser, that's an excellent question. And the reason it's an excellent question is I'd say it's on our to-do list. And as a matter of fact, so a lot of, and I'll just backtrack a little bit, a lot of the funding around this was around operational dollars. And the way that we were able to negotiate the operational dollars was to look at the cost of transcription and coding and abstracting and sort of look at it as a cost avoidance strategy. And also through application to granting agencies to be able to support this. So we do have, some small grants within, various clinical departments of the university. We have some Ontario ministry money, and we're in the process of finalizing some InfoWave money around these sort of initiatives. In the grant that we'd like to sort of get out there and sort of achieve is to do more of the work that you're talking about, Fraser, and that's to go to the individuals that are making the referrals and receiving the information. We've done a little bit of that informally by going to various referring docs in our own family medicine unit. We haven't done it systematically. My sort of theory on this is that we may want to generate 2 or 3 versions of the report. And if I'm looking at a surgical note, there's the full-blown, detailed surgical note indicating everything from, which electrocautery device that you had pulled from your surgical, sort of equipment system and all the vital signs and everything, that would serve as the comprehensive record, the medical legal report, to the scaled-down summary that would go back to the community-based physician, right? And then there may be some in-between sort of report. With the standardized formatting, it's very easy. Because you just look at different reporting templates that would be able to fit that. We haven't yet taken the usability and the focus group and that sort of methodology out to the users, very much on our to-do list. And that's the sort of thing that we'd love to do and collaborate with other groups provincially and nationally.
And if I could just add that, we've seen some kind of funny things happen over time. So with our OR procedure notes, a lot of our surgeons are doing it in between cases while the room is getting clean and they're waiting. So what's happened is the floors are now looking for those reports, and now they have a sense of, as the patient's coming up, what's happened to them, whereas before they'd have to wait till the end of the day when rounding happens to get a good sense of what happened. So we've received some feedback from those groups that they like that. And then the other component is with our medication reconciliation implementation. We have a pharmacy component where they can write letters based on the meds and the discharge summary and add some additional information. And what we've seen there is that we're starting to receive letters back from other organizations. So if they get transferred to a rehab a hospital, they're now getting very nicely written letters in the same format we've been sending them of a summary of what happened. So we start to receive a lot of the outputs now that we're getting. So patients are coming back to the Emerge, they're coming with that wallet card that's generated from the discharge summary with their meds. So we started to not only impact the community, but start to receive some of the community outputs that we're generating.
And I think there's a whole science around communication that we really haven't tapped into. And, there's been a little bit of literature, just sort of scratching the surface of balancing discrete synoptic reporting with a more sort of subjective narrative when it comes to clinical encounters. And I think all of us can sort of relate to that, whether we're clinicians or receiving care. You may see, let's say, a patient who has their gallbladder removed, but there's something unique about that individual. And, even a lot of surgeons, I say this with great respect for my surgical colleagues, may want to mention that, the person's an artist or, those kind of things that aren't, part of a discrete sort of codified sort of report. It may have an impact on recovery times, one's perception of body image, depending on, what's happening. So it's very important information. And once again, I think we have to sort of look at the science of communication, especially around interdisciplinary care, how we communicate when we engage patients more through personal health records, and I'd say how we leverage technologies like natural language processing so that we're not as saddled with, this kind of structured reporting, which is necessary so that you can get it done within a period of time. So as we can speed up, the human interaction through, natural language processing and other technologies, along with making intuitive interfaces that will code the information on the fly, I think we'll end up with much better sort of tools and products in the very near future.
So right now, I think the statistic was 92% are done within 14 days. So given the incentive about the 48 and 48, what's the percentage of notes being completed within that 48 hours?
It was 74%. You had that up the slide.
Wow. So that's great.
Yeah. A lot of physicians didn't even know about the $48 extra fee code. So that was an extra carrot in our bag that was usually kind of, hey, are you getting the extra money? What extra money are you talking about? So we were able to use that as kind of...
And then, so you're talking about the physician actually doing it, as they, in between cases in the OR. So what's the percentage that are actually being done, let's say, within 24 hours?
Don't know that.
I don't know if we have the stats on the OR notes or anything recent. Yeah, but that just reminded me, one of the questions you had asked earlier about getting clinician buy-in, I would think of when we were doing the hip and knee notes for Dr. Davey, one of our, the head of our orthopedic group. He basically, his challenge to Kelly at that point was, I can dictate my note in under 2 minutes. You need to match that, or I'm not going to do it. And we did. So yeah, he can do an online note in under 2 minutes. So it built out to support that. So that was the big challenge. Again, the whole thing about usability.
Yeah.
So,
was he able to do that intuitively right away, or did he have to have like a week of pain before? Not pain, but frustration, more than 2 minutes for him.
I don't think it was a week. There's always a learning curve with something.
For sure.
But the notes are so straightforward.
Yeah.
We try to follow their clinical practice as much as possible. So where you would find the content is in relation to the process of where it would be. Try to make it as intuitive as possible that way.
Yeah, so I don't think there was a huge learning curve with that. We've done similar studies when medication order entry was implemented within our EPR. There were studies that were done that actually looked at the learning curve for physicians to get productive doing that. But it was never really an issue for us, so we didn't bother.
So maybe just two comments, just to follow up on Fraser's, and one is, in addition to the transcription time, if these notes are structured, this is also on our to-do list to really deliver more value at the time of the clinical encounter. So I'll give you a couple of examples. So with most, let's say, surgical or endoscopic procedures, there's often an order placed for a pathology specimen or specimens, right? And so you can quite easily see that if you're documenting and you build interfaces into your pathology order entry system, you can actually not only document, but you can generate your pathology orders, because with the work that's been done through CPAC, is already synoptic pathology, especially around cancer surgery and endoscopy. So right now, those are occurring in most organizations in a siloed way that allows you to drill in. The other sort of financial incentive that we look at layering in, because it's really just generating a report, would be to put in the provincial billing codes. Because it's quite easy to see that if you click off, you did an assessment, and then you did such and such a procedure, most of those break down and they match to fee schedule. So we can actually, and I've spoken to our billing administrators for the various departments in the organization. All we have to do is build an interface into their billing systems, and we'll eliminate all of that extra work that the clinicians are doing now. So even sort of salaried or alternate funding plan positions in most organizations do have some kind of a shadow billing process to look at clinical activities. So if you're able to capture that on the back end, that really sort of drives the value and the adherence. So if you do that, I would say it would really push you to that 100% completion rate on there. Then there are other things that are mandated. Some organizations will actually tell surgeons, we're pretty close to this on some of our notes, you will not be able to start the next case until your documentation is complete.
Yeah.
Okay. We already do that around the pathology order entry, and the idea is we do not want specimens in the procedure room that are part of another case, because it just increases the risk of error. As soon as we have tools that are intuitive enough that will meet, that sort of guideline where, they're time effective, we will mandate that your next case does not start until you've completed that.
I think the key is to make it seem like it's not administrative work and that you're offloading a lot of the work to physicians, but to try and incorporate as much of their everyday process or things they would have to do on the side later on under one umbrella. So it might be an extra minute or so up front, but I'm saving you some time downstream. So you now don't have to go down to health records and sign that piece of paper, right, or have to review the dictation before it's released. We're saving you time up front by just clicking this button.
And sort of my final comment, and this ties into yours, Cassie, the biggest challenge that we actually had is not so much the application, it's accessing a device. Like, in other words, you need, and the device for most organizations is a PC, right? So if you're talking about having completion of discharge summaries, if you have a very busy nursing station and they're running out PCs, then that pretty well kills it right then, because the person's unable to actually get onto the system and access it. The other one, and Tim sort of alluded to this, is if you're dependent on your network or Citrix and or both, and the forms don't load properly, or if you type a letter and then there's a lag, then that user adoption falls off. We had issues where the application was fine, but it would freeze in the middle, or the network would drop off, or let's say the individual was distracted for a moment, they had to get to the phone, and then the system timed out. They'd have to re-log in and relaunch and everything else. That's where you sort of lose the user. So the reason I'm mentioning that is in case there are any sort of IT sort of management people or people who are looking at that, Tim sort of emphasized that at a high level, but it actually comes right down to the level of the device, accessing the device, the reliability of the device, your single sign-on capabilities. Like, that is all bundled in to how motivated and how able clinicians will be to use documentation tools.
Great. So one final question for the team. So what has the challenge made you do differently?
We started looking at numbers.
Yeah, because we had to report, we actually started looking at our numbers and thought, wow.
I think going through the Trailblazer plan helped us too. I mean, there's always the next step component, which makes us think about where we want to go next also in expanding. I mean, like in one way we try to promote within even our organization what the work that we've been doing, but how can we expand beyond?
Yeah, it actually helps us put some thought around, what our next priorities need to be.
Yeah. We're planning ahead, and Fraser, questions like yours, like what about the readability of the reporting? Those are key sort of questions. You expose yourself when you enter something like this in a very positive way. Mm-hmm. Oh, good.
That's the end of this webinar. Thanks for joining us. You can get more detail about InfoWay's Imagination Outcomes Challenge at our website. The challenge runs until March 2013, and it's not too late to register. Remember, the sooner you join, the better your chances. Have a great day.